So I'm going to talk to you about the MOSES trial that we intend to commence after completing this project that has been kindly funded by Oracle. So we're hoping that MOSES shows the way in managing this thorny problem for us. So like Adrian said, patients usually with head and neck cancer can present with disease in the neck, and that's an indication of the cancer having spread into the neck. Ironically, in a small proportion of patients, we see neck disease, but we don't see the primary site. We don't see where it's arisen from. We do all manner of scans, CT scans, MRI scans, PET scans, but we don't see the primary site. That becomes a problem for us because without knowing where the primary is, we can't offer the patient comprehensive primary cancer-directed treatment. And this is especially seen in the HPV era. So with the number of HPV cancers going up, because we have seen nearly more than doubling of the numbers of HPV-related cancers in the UK and the Western Europe and USA. And particularly HPV-positive cancers present in this manner. With a neck lump, do all manner of scans, and there is no primary site to be seen. So what we do at this point in time is we do a comprehensive endoscopic examination, and we go inside and we take away the patient's tonsils. And we do that because we can easily access the tonsils. And we send them for analysis, and many times the tonsils don't show a cancerous focus. So we are really, we are grappling in the dark with this thorny problem, and we can send the tonsils away. We don't find a cancer, and we then move on to treating the patient. And the conventional treatment is to offer the patient radiation therapy to the neck and to the part of the throat where we speculate this cancer could have arisen from. So a lot of speculation happens here. So since transoral robotic surgery came into being, we are now able to access parts of the throat that we couldn't in the past, particularly the back of the tongue. So I'm sorry about the gory picture, but that's the front of the tongue. The yellow shaded area is the back of the tongue where these HPV-related cancers can reside. And in the past, we've never been able to take that lining of the tongue away for analysis because it's around the corner. And if it's not in line of sight, it is quite difficult to access that area. For instance, in the past, when we had cancers here, to surgically take those cancers out, we had to split the jaw just to get to that part. So it's quite a difficult, awkward to access site. But in the robotic era, what we can do is, we can use a robot, and that's a robotic arm, 2 arms here, and 2 of my assistant's arm. The whole thing is done through the mouth. We just go in and peel away the lining of the back of the tongue where the cancer may reside. This takes about 30 minutes or so to do, compared to in the past when we just couldn't even do this procedure. So that's what transoral robotic surgery offers us in terms of access, in terms of the ability to take away the lining of the back of the tongue in a limited amount of time. So that's what it looks like when it's done, and that is then sent away for analysis. Okay? So we did this piece of work, and I'll show you some data on this. And this piece of work is now considered to be part of the investigative protocol in centers where robotic surgery is available. But it's important to consider the fact that we don't know how to use this information. So this is what MOSES aims to do, and this is what Oracle has kindly funded. So we aim to generate high-level evidence to define the role of this particular procedure in managing head and neck cancer patients with an unknown primary. That's our aim. So we've done a fair amount of pilot work to get to where we are now. So first we did a national survey. With the number of patients with HPV-related cancers going up, we wanted to ensure that this was a topical question. We did a national survey, and among the top 3 head and neck cancer research questions, this came out top: treatment of unknown primary. So we recognize there is professional interest in researching this particular problem. Then we did a survey. So as I said, we don't know how to manage this condition properly. So we did a survey. We gave the same kind of tumor site and stage to 30 oncologists across the country. And we got a variety of answers. And that clearly indicates that there's no consensus on management, not because it's simply because we haven't got enough high-level data to manage these cancers. It's not because we're doing it wrongly. It's because we just don't have the high-level information. And that is the aim of this project, to generate a high-level data, high-level information that will allow us to manage patients based on a robust evidence base. We then, across Newcastle, Oxford, and London, performed this piece of work. Stuart Winter, who's in the audience, led this piece of work where we looked at 32 patients who were all scan negative, who had a tongue-based mucosectomy done. So before they had the tongue-based mucosectomy, we did not know where the cancer was. And all of these patients had a one-sided neck lump alone. Okay? So once we did the tongue-based mucosectomy and performed what we call conventional histology, straightforward histology, we found the cancer in 53% of patients. So we bumped up the unknown primary by 50%. What's interesting is that in 12%, it was on the opposite side of the neck lump. So conventionally, we wouldn't have treated the opposite side if there was low volume neck disease on one side. But clearly, that is interesting information to have. And I'll put my hand up and say, we don't know how to use this information effectively. So that's the third piece of pilot work we did. We also confirmed that we didn't delay cancer treatment in these patients by doing this piece of work, by performing the surgery on them, because it does take a while for patients to recover from this operation. So we robustly looked at recovery, and we know that as long as we offer patients radiation therapy within 6 weeks of surgery, we're good, and we confirmed that we are not delaying cancer treatment by performing a tongue-based mucosectomy on these patients. We established that. And this is the final piece of jigsaw we did before heading on to the MOSES that Oracle has funded. So conventionally, once we do a mucosectomy, we just send them for pathology. And all the pathologist does is they take some sections. So in a mucosectomy specimen, for instance, what they would do is take a few sections and send them for testing. And these sections are usually 5 millimeters to 7 millimeters apart. But these are small cancers, and we thought we don't get the full information from performing 5, 7 millimeter cuts. So I went to pathology and said, can we do something better, something closer, so we can get further information on these specimens? So there is a technique called step serial sectioning, where we section at 150 microns. So really close sections to look for cancers. And this is done in neck nodal disease, like what Adrian said. When we don't know if the tumor is spread or not, we sometimes do this on neck nodes, but it's never been done on mucosal specimens. So we started doing an SOP for this. So did this piece of pilot work, and the pathologists now hate me when I go to the department, but this is what we did. For example, a mucosectomy, these are 50 micron sections, 50, really close together. So conventional pathology was 5 millimeters. These are 50 micron sections. So we did this on 8 patients so far. These are 8 patients. This piece of work is again fairly part of the pilot work leading to MOSES, funded by Oracle. So this piece of work on 8 patients in whom conventional pathology showed no cancer. So we did step serial sectioning. We found 1 of 8 where the cancer was on the opposite side. So these are patients with one-sided neck disease. Using step serial sectioning on 8 patients, we found 1 patient on the other side. So I have no idea what to do with this information. So that's what MOSES plans to do. MOSES will generate an SOP. So we've done it on 8 patients. We have the SOP, I think, at this point in time. But we also intend to use this information by generating consensus on treatment after tongue-based mucosectomy and step serial sectioning. And once we do that, we will identify the question we need to ask when it comes to managing this group of patients. So that's where we are at. So that's work program 3, and that's the whole thing is going to be run at the Royal Marsden by a dedicated fellow, John Hardman, who's on Crete on holiday. That's why I'm doing this talk here today. So, and that's the aim of the entire funded trial. Thank you so much for your attention. Thank you.